Hey guys, it's Dr. Oliver. This is a quick lecture on pneumonia, different types of pneumonia, what it looks like in your patients, how you would handle that in the outpatient realm. So if you have any questions throughout, just make sure you write them down, bring them to class, or shoot me a quick email and I'll get back to you about them. Now, I'm sure many of you are familiar with pneumonia. You may have had a family member that have had it, or you've taken care of patients that have had it. As you know, there's different categories of pneumonia. So pneumonia in general is just defined as an inflammation of the lung, and it can be caused by bacterial or a viral infection. And it's basically when the air sacs fill with pus and then they can become solid. So the different categories of pneumonia, and the one that you will typically deal with is the community-acquired pneumonia. You will see these patients all the time. I personally have had this twice. It's that, people also call it the walking pneumonia. These people are just living about their normal lives out in the community, and they come in contact with someone, and then all of a sudden they've developed this community-acquired pneumonia. For people that you have to really be concerned about are those younger patients or the older patients with multiple comorbidities, people that might have a little bit more difficult time fighting off that bacterial or viral infection. So those are the ones that you're going to want to be extra careful when you are treating them. Some other categories include that healthcare associated pneumonia, and I'm sure all of you, if you're working in the hospital, have heard of this. It's that HCAP. That also is subdivided into hospital acquired pneumonia and then ventilator associated pneumonia. There's also aspiration pneumonia, which some of you may be familiar with. Me working in palliative care and hospice when I first became a nurse practitioner, aspiration pneumonia was so common in people that were a little bit more progressed in their disease state. So this was something, it's treated a little bit differently. So because you also have, you have these gastric contents that have now found their way into the lung, and then you're also, an infection has developed as well. So there's even more inflammation than with regular, I guess if you would say regular pneumonia. So there's a little bit different method to treating that. And a lot of the times when people are aspirating like that and it does turn into pneumonia, a lot of the times they are hospitalized for that and they're treated with IV antibiotics. So just keep that in mind. So first we'll focus on this community-acquired pneumonia, or CAP, as you'll hear some people say. A lot of the times the pathogens that are involved with community-acquired pneumonia, a lot of the times they're only detected 30 or 40% of the time. So roughly about 2/3 are viral and then about 1/3 are bacterial. So you may see a lot of providers that you end up following in your clinicals. If somebody comes in and they have some symptoms that are possibly suspicious for a community-acquired pneumonia, the physician or nurse practitioner that you're following, they're not just going to base it off of their symptoms. They want to know the duration, how is it affecting their life, and then they also want to associate physical examination findings with that, because you have to be able to differentiate between viral and bacterial. I know you guys have probably seen the signs at the hospitals and in physicians' offices. We're really trying to try to scale back our antibiotic use, because we tend to, in our society, use a lot of antibiotics, and then that's why we're having a lot more resistant organisms. So it's important that you take the time to differentiate between viral and bacterial. So typically, a viral infection will come on quickly. So when you have a person that comes in and says, oh, I've been having this cough, this wheeze, this tightness in my chest when I breathe, that's been going on for about 2 or 3 days, and I'm just tired. I've been running some low-grade fevers. It would make you more likely to suspect a viral infection, because it really hasn't given bacteria a whole lot of time to settle in there. Now, if that same patient came in and they say, oh my goodness, this has been going on for about 8 or 9 days, at one point I thought maybe I was getting a little bit better, but now it's just really hit me hard, and I just cannot stand this anymore. So that would make you kind of think, well, maybe it started out viral and then now it worked its way into a bacterial infection. So at that point, then you would start considering an antibiotic. So patient's presentation may suggest a specific pathogen. So for example, usually some of the more common offenders are the pneumococcal pneumonias. You may even see some Legionella. Haemophilus is common in COPD and smokers. Staphylococcal, Klebsiella, that's not quite as common, but in alcoholic patients it can be. And then you have your atypicals, like your Mycoplasma pneumoniae, the Chlamydia pneumoniae. Those are a little bit more rare, but they can occur. So in pneumococcal pneumonias, usually you'll see focal infiltrates on a chest x-ray. Usually they'll have a sudden onset of fevers or chills. Sometimes they'll complain of, you'll actually be able to see them chilling. And then they tend to complain of a pleuritic type chest pain. They'll have possibly a productive cough. A lot of the times it might come out as a rust-colored sputum. People may say, oh, it just, I keep coughing up this brownish red gunk and it tastes like metal. That is something that I hear all the time when people come into the hospital, and I've experienced myself when I had that walking pneumonia. So it really does look like that, and it does taste, it has like a rust flavor to it. And then, like I said, that's your walking pneumonia. So Legionella, a lot of the times when these people come in, they are sick. A lot of the times when a person does have Legionella, what would make you possibly lean towards that diagnosis would be if they are coming in and they've had some GI complaints for the last few days to a week before, and then now they have these respiratory symptoms. If you're doing some lab work, you may see an elevated LDH or some hyponatremia going on. There's also a urine antigen that you can check for Legionella as well, and we do check that when they come into the hospital. Haemophilus pneumonia, so like I said, it's associated with COPD and smokers, so that's something to just kind of keep in the back of your mind. You should always be asking your patients if they smoke. A lot of the times on the chest x-ray, there'll be patchy lobar infiltrates. You'll see those. And then staphylococcal, a lot of the times, and this is why people that come in with influenza and it's diagnosed influenza, they, we'll get their symptoms under control, or maybe we started them on some Tamiflu, and then all of a sudden they say, I was feeling so much better, and then now I just really feel like crap. That's when you are a little bit more suspicious that, okay, maybe this has now turned into a pneumonia with that Staphylococcus. So it's rapidly progressive. Usually it's bilateral involvement. So when you are doing a chest x-ray, a lot of the times you'll see it on both sides. So Klebsiella, like I said, it's associated with alcoholic patients. They may complain of this red jelly-like sputum that they'll cough up. And then again, you'll be able to see that on their chest x-ray as well. Atypicals, they aren't as common. They do have a little bit more gradual onset. So this is why it's important to get a good subjective history to see the duration of a person's symptoms. Usually they'll have a non-productive cough, and then a lot of the times they'll complain of a headache as well. So these are treated just a little bit differently, but it's important to get that good subjective history, to do a good physical exam. You can't always depend on the chest x-ray. So think back into that health assessment course and all of the different exam techniques that we did for the respiratory system. This would be the perfect spot to do that. Now, even though we're kind of focusing more so on outpatient, I did want to, I think it's important for you to also understand the hospital atmosphere as well. So, and also if you have a patient that is a resident at a long-term care facility, and possibly they're coming to you for, for a checkup or for these symptoms that they're complaining of, that would be considered a healthcare associated pneumonia. So it's a pneumonia in any patient who is hospitalized for 2 or more days within 90 days of the infection, but it also includes residents in a nursing home or long-term care facility, patients who receive recent IV antibiotics, so these are people that might be going over to the infusion clinics, chemotherapy, so your oncology patients, or wound care within the last 30 days preceding the current infection, or possibly a dialysis patient too. So you have to think about, the population that your preceptor is seeing, and that you may possibly be seeing once you are done and graduated out of this program. If you're seeing a lot of these patients, it you may bypass that community-acquired pneumonia definition because they now fall into the healthcare-associated pneumonia. So the one of the biggest issue with the healthcare-associated pneumonia is that now we have to be concerned about multi-drug resistant pathogens. So some of these include S. pneumoniae, H. influenzae, MSSA, the gram-negative bacilli, so E. coli, Klebsiella, Enterobacter, Proteus, or Serratia. So a lot of these, and you have to look at how sick the patient is as well, but a lot of these do better when they are treated with IV antibiotics. So a lot of these patients end up getting hospitalized. So again, when a person comes in with a suspected pneumonia, it's really important to get a good patient history, and then also for you to do a complete respiratory exam, and then also include other systems if needed. So you possibly will throw in some lab work there, some imaging, maybe a chest x-ray, but it's important before you even start looking at that objective data, you really need to get a good subjective history. So we want to look at, duration of symptoms. Are they having a cough? Is there sputum production? Are they having shortness of breath? Is there any hemoptysis? Is there chest pain, wheezing, recent sick contacts, any travel to possible areas with endemic conditions? Then we want to ask them about any constitutional symptoms. So are they having fevers, chills, any weight loss or night sweats? We want to ask about a history of any prior respiratory infections. Do they have history of asthma? Do they have COPD, or do they smoke? And if so, how much? These are all very important questions. Then you want to ask about the history of any recent antibiotic exposures, any hospitalizations, and then any risk factors for or any risk factors that might possibly throw them into the healthcare-associated pneumonia category. Then we can move on to our physical exam. So just some common physical exam findings that you may see is they might be real short of breath, they might have a fast heart rate, they might have a fever, could be low grade, could be high, or even could be low too, depending on how sick they are. Might notice some crackles, rhonchi, or wheezing on exam. You might notice that in the case of mycoplasma pneumonia, they might have some skin lesions that you might see. You also, just because you are ruling out pneumonia doesn't mean that you can't forget about the cardiac system, because although you may be convinced that this is pneumonia, you may be surprised it may actually be maybe an exacerbation of heart failure. So I always, whenever I have a person that comes in with respiratory symptoms, I always do a full cardiac assessment as well, because they may end up surprising you. So you always want to assess for signs of heart failure, and that includes jugular vein distension or peripheral edema. You always want to assess for this. Some common lab work that might be included would be a CBC, a CMP, an ABG if it's clinically indicated. If you think that a person needs an ABG and they are in your office, I would highly suggest that at that point you probably need to consider them going to the ER to get evaluated. Again, I said we could do that urine Legionella, so if that's something that you think needs to be done, if they have the risk factors for it, then I would highly consider that. They can also do S. pneumonia urine testing as well. You might possibly need an influenza swab. For imaging, you can do a chest x-ray. Some, depending on if it's more of like a pneumocystitis, it might actually demonstrate a normal chest x-ray, so it just depends. If you are seeing a cavitary infiltrate, that should prompt for possible fungal pneumonia or a mycobacterial infection. These patients, especially if they are coming in and they have a history of cancer, or especially if they have current cancer, or if they are in any way immunocompromised, if they have rheumatoid arthritis and they're on immunologic drugs, then that's something to always kind of keep in the back of your mind, and it should prompt some more questions. In some situations, you might have to refer them for a bronchoscopy, and that would be where you would definitely need to involve a pulmonologist. So if you think that they might possibly need hospitalization, that's when you want to utilize the CURB 65 scale, or they have a pneumonia severity index, or it's a PSI index for community acquired pneumonia. These are great. I have an app on my phone. It's the MediCalc app, and I use that all the time. And they have these scales on there, and all you have to do is answer the question, and then it'll give you the score, and it'll have a what that score means. So I would suggest finding an app that you like and then utilizing that, so that when you have a patient and you need to use any sort of scale, or if you need to calculate BMI or anything like that, it's just easy to put that in and get that answer quick. Now, I will tell you, when I was in school, these guidelines were a little bit different for me. This was actually something I was talking to Lindsay about, because her and I graduated the same year. So these change. So this is something, these are guidelines that you need to periodically stay updated on, or look up, or however you decide in the future to stay updated. This is something that you want to keep in the back of your mind, that you need to check on every once in a while, because they do change. So if you have a healthy patient and they have no risk factors for any drug-resistant organism, and they've had no antibiotic use in the last 3 months, they now say the first line is a macrolide. So we're looking at clarithromycin or azithromycin, or doxycycline. Now, I will tell you, if you have a patient, an older patient that comes in and they have this community-acquired pneumonia, if they have any sort of kidney disease, doxycycline is actually going to be your choice, because it's not, the side effects of it do not affect the kidneys, so that is a safer drug for them to use. Now, if you have a patient with multiple comorbidities, or maybe they've used some antibiotics in the past 3 months, or maybe you are concerned about any drug-resistant organism, then you're going to use a fluoroquinolone. So moxifloxacin, Levaquin, that's probably the more common one that you see. Although, again, with any of the fluoroquinolones, you have to be careful if you're utilizing it in a middle-aged adult or even a younger adult. You have to be very cautious of their use because of the tendon rupture side effects. So you have to you just have to make sure with that, and also follow up with them appropriately. The other thing that you can use is a beta-lactam, preferably a high dose of amoxicillin, so they need at least 3 grams a day. And as you can see, a lot of these medications are from 5 to 7 days. Back 10, 20 years ago, people were prescribing for 2 weeks. Well, now they're finding that it's just as efficient for 5 to 7 days, and it actually helps prevent any drug resistance. Augmentin, you can also do 2 grams twice daily for 5 to 7 days, plus a macrolide. I will tell you, when I was in school, Augmentin was the first line for pneumonia. So, like I said, just make sure that you're always staying up to date on this. Never stop learning. So in regions with a high rate of high-level pneumococcal macrolide resistance, so this is a resistance to like azithromycin, which Ohio is considered a high-level area, then you need to consider some of the other alternatives listed above. Now, like I said in the beginning, so the treatment for the healthcare-associated pneumonia, I wanted to include that on here because you never know. I never thought that I would end up back in the hospital, and I love it. I can't imagine myself outside of the hospital now as a nurse practitioner. And, as of right now, family nurse practitioners can still see patients in the hospital. We just can't see the acute care patients. So, if that's something that you're really interested in, come talk with me. I have some great resources and books and apps and things like that I could show you if that's something that you think that you'll be interested in. Or, see if you can find a preceptor to follow in the hospital, and I can give you ideas on that as well. So typically, when a person comes into the hospital, if they are sick enough to be admitted to the hospital for pneumonia, we are going to use IV antibiotics. And typically that first choice is ceftriaxone. That is the first line. If someone is allergic to that, you can look at Zosyn, or if you notice that their symptoms are just really overwhelming them and they're sick, that's when I would consider like a Zosyn or a Levaquin. There are other different combinations that you can use, and there's tons of algorithms out there that you can look up for the healthcare associated pneumonia. And I would suggest, like I said, if you plan on working in the hospital, I would suggest saving those or having them in a place where you can access them when you go to your clinicals or when you eventually work in the hospital, because they're just nice to have. I like algorithms because they're easy to access and quick to read. However, you do have to make sure that you are staying up to date, because like I said, with the community acquired pneumonia, they do change frequently. So a lot of the times, once the patient is stabilized, we can switch them from IV medications to PO medications, and that's the goal. We want to try to get them off of the IV medications as soon as possible, but they have to be stable, and they have to be able to swallow okay too. This slide is just some special considerations that I think are important for you to know. Like we just stated, a patient, if they're started out in the hospital on IV antibiotics, we want to try to switch them to those oral agents as soon as possible. And then, like we also said before, back on the community acquired pneumonia, historically people were treated for 10 to 14 days, but research and the CDC guidelines state that a 5 to 7 day course is sufficient. So just keep that in mind. Now, if you have a patient that isn't getting better, that's something different. So that you need to cater to that patient. So sometimes patients need to be switched to a different medication, or perhaps they need a longer dose of that antibiotic. So it's case by case. Now, you can always tell the patient that fever and leukocytosis usually resolves within 2 to 4 days. So I always tell my patients it's going to take probably a good 2 to 4 days for you to start feeling better. Symptoms sometimes do not completely resolve those. So if they have cough or sputum production, sometimes those don't resolve completely for up to a month. And that's why in the first 1 to 2 months, they don't suggest doing a repeat chest x-ray, especially if you're seeing them out in the office. It really, chest x-ray abnormalities are going to take about 4 to 12 weeks to clear. So that's just something to make sure that people are aware of. Also, when they're stable and they're starting to feel better, if they haven't already, you really need to talk to them about the influenza vaccine, and then if appropriate for that patient, then the pneumonia vaccine. So those are something that we always need to be educating our patients on. That concludes the lecture on pneumonia. Again, that was a brief overview. Hopefully you were able to write down some questions or some thoughts that you had about the lecture. Bring those to class when you come. We can go over those. Or, if you think that you need to research a little bit more a certain topic, write that down and go utilize that Nursing Central or whatever app or program that you utilize. You can also utilize your book if you did end up purchasing that. I tend to find the app is a little bit easier. But if you have any immediate questions, feel free to shoot me an email, okay? Thanks, guys.